Good evening, and welcome to Sickle Cell Today, a webinar that's focusing on one of the most important rare diseases in America, sickle cell disease. My name is Reginald French, and I am the president and CEO for the Sickle Cell Foundation of Tennessee, and I will serve as your host on today for Sickle Cell Today. Today, we have an extremely exciting show. One of the most important topics that you can talk about, not only in sickle cell disease, but overall just in healthcare. Today, we will be talking about healthcare disparities, or some call it healthcare equity. And one of the things that you talk about when you talk about healthcare disparities and healthcare equity, you're primarily talking about how is that actually administrated for everybody in America. Not only those individuals that have sickle cell disease, which will be our topic today, but many other illnesses, in particular illnesses that plague the African American community. Today, we have a very, very special show. We have three very, very special guests. We have someone that you may or may not have heard of, but she's extremely famous and well renowned in the field of sickle cell, Dr. Maria del Pilar Aguinaga from the prestigious Marrow Medical College. Additionally, we have Tabatha Marmon. Ms. Marmon is a sickle cell warrior, mentor, national speaker. She just does it all. Also a board member for the Sickle Cell Foundation of Tennessee. And lastly, we have Ms. Yvonne Carroll. Ms. Yvonne Carroll works at St. Jude Children's Research Hospital. And as we get to each one of their presentations, I will share with you more information about them as we get to their respective presentations. So at this time, I would like to bring up our very, very first guest. Let me first introduce you to Dr. Maria del Pilar Aguinaga. She's currently a professor in the Department of Gynecology at Marrow Medical College. Her research includes sickle cell disease and many other specialties. At this time, I would like to begin with Dr. Aguinaga to tell us a little more about herself, and she will focus on something that's very important. She's going to talk about sickle cell disease from birth to childhood up. So thank you for joining us.
Good evening. Thank you, Mr. French, for the kind introduction. And I would like to thank the Sickle Cell Foundation of Tennessee for the invitation, and also Kutsukian for broadcasting this program. Today, I'm going to talk about the diagnosis of sickle cell at birth in the state of Tennessee. I'm going to share my screen. I have no disclosures, no conflicts of interest. Newborn screening is a mandatory state public health program in the United States that focuses on identifying fairly early in life genetic and congenital disorders in order to procure treatment of these disorders, to prevent the mortality and morbidity associated with these genetic disorders. There is a committee known as the Advisory Committee on Heritable Disorders in Newborn and Children. And what they do is they focus and determine which genetic disorders should be screened at birth. And they have come up with 35 core disorders and 26 secondary disorders. And that is called the RUSP, for Recommended Uniform Standard Panel. And as you can see, it includes sickle cell disease, homozygote, sickle cell anemia, sickle beta thalassemia, and hemoglobin SC disease among the core disorders. In the secondary disorders, it includes various other hemoglobinopathies, which could be the thalassemias and those hemoglobin variants that can produce disease. We have in this country about close to 330 million people. And we produce about 4 million births per year. From these 4 million births in the 50 states of the Union, we perform newborn screening. Every year, about 5,000 babies are identified with severe genetic disorders, and among these, about 2,000 have been identified as having sickle cell disease. Sickle cell disease is definitely a health disparity because it affects minority groups, and there are several barriers in access to care, including economic barriers. The presence of the sickle cell trait in the African American population is 1 in about 13 people. And we have about 1 out of 365 African American births today that are born with sickle cell disease. And we have about 1 in 36,000 births with sickle cell in the USA Hispanic population in the West Coast, and about 1 in 1,100 in the USA Hispanic population in the East Coast. We also see sickle cell in other groups because of admixture, like in the Native American population and in Caucasian population, but a very low incidence. But in general, sickle cell is prevalent in people of Mediterranean, Middle Eastern, Indian, Caribbean, South American descent, and of course, in people of African descent. When a baby is born, between 24 and 48 hours after birth, a blood sample is collected from the little heel of the baby and is spotted on a filter paper. These are called dry blood samples. These are sent to the Tennessee Department of Health Public Health Program in Nashville for testing for 70 genetic disorders, one of them sickle cell. Since 1989, Meharry Sickle Cell Center became the designated confirmatory and reference laboratory for hemoglobinopathies for the state of Tennessee. In Tennessee, newborn screening started in the late 60s with a handful of genetic disorders, one of them sickle cell. However, Meharry Medical College, as an HBCU, was doing testing for population at risk since the late 50s, soon after the technique became available. We had a Japanese hematologist, Dr. Saburo Ohara, who was the first lab director for the Sickle Cell Center. In Tennessee, we have 4 regions, and each region has a sickle cell or genetic center. We have in West Tennessee, St. Jude's, in Middle Tennessee, Meharry, in Southeast Tennessee, T.C. Thompson Erlanger, and in East Tennessee State University. If a baby is born in Middle Tennessee with sickle cell, then Meharry will do the follow-up in our region, which means that the baby will first be brought to Meharry for a physical counseling and education of the family, and also the baby will be placed on prophylactic penicillin. Then the baby will be referred to tertiary centers, Vanderbilt University, or Centennial, according to the preference of the parents. I have collected surveillance data for sickle cell in our state, and I'm going to present the data for the past 20 years. And we can see in the case of homozygous sickle cell anemia, it has been coming down. So the incidence looks higher because it has been coming down. And if we look at the graph, and this is for sickle cell anemia, for 100,000 births in Tennessee residents, we see that for the first 10 years of this data, really there wasn't much of a change. But interestingly, since 2014, we have been seeing a decrease trend for sickle cell anemia, and it's the same for sickle cell disease. If we look at the total number of cases of sickle cell anemia in blue versus sickle cell disease in orange, we will see in 5 years intervals that in the past 10 years, from 2011 to 2018, it has been decreasing compared to previous years. And for the homozygous sickle cell anemia, we see something similar. Since 2011, 2014, we have been seeing a decrease compared to 1999. So right now, among Tennessee residents, the incidence for 2018 is 1 in 1,583. The incidence in the country is 1 in 2,375 births for sickle cell disease. And this is irrespective of race, which makes sickle cell disease the most common genetic disorder identified at birth by newborn screening. Thank you. I would like to thank my co-workers at the McHarry Sickle Cell Center, former McHarry medical students that now are doctors who have participated in this research and data collection, and the Tennessee Department of Health, the Nashville Duffers Golf League Inc., and the National Sorority of the Phi Delta Kappa for funding. And I would be glad to entertain any questions under the chat when there is time for questions. Thank you. Mr. French, would you like to go to the questions now or at the end of the program?
Thank you, Dr. Aguinaga. That presentation was extremely, extremely well. A lot of information that you gave to the audience are questions that many ask about just to state.
Thank you, Mr. French.
No, we're actually going to answer questions at the end of the program.
All right, thank you.
So we'll answer questions then. So we'll get prepared to answer our next guest that we have. And that our next guest is going to be Miss Tabatha Marmon. As I indicated earlier at the beginning of the show, Miss Marmon is a sickle cell warrior. She's very active with the Sickle Cell Foundation of Tennessee. And I'd like for Miss Marmon to begin and start talking about her lifespan as a sickle cell warrior, as well as some of the experiences that she's experienced as relate to disparity as growing up.
Hello, everyone.
How are you?
Good. How are you? Can you hear me? Am I coming in clear?
Hi, Tabatha. How are you?
I'm good. How are you?
Thank you and welcome you for being on the show.
Thank you for having me.
Can you hear me?
Yes.
Absolutely. Sound very clear. So I've already introduced you. So Tabatha, it's your part. Tell us about just growing up as a sickle cell warrior, some of the experiences you experienced throughout life. And it's kind of your time to talk. And then at the end of the show, we'll answer any questions and we'll focus on some of the disparity issues at that time.
Well, I have to start off by saying that I'm 35 years old. I just had a birthday. So I'm very grateful to be 35, surviving with sickle cell disease. This disease is difficult because it's so unpredictable on how to deal with it, how to continue this process in a healthy way, and the relationships that you build having sickle cell disease with the medical field is really important. And I've taken great pride being an advocate and a warrior and a public speaker because my relationships with people in the healthcare field have been so great. My experience is not the experience of everyone living with sickle cell disease. We all are so vast and so different that our experiences are as many as the different types of hemoglobin for sickle cell disease. I have hemoglobin SS, and my experiences are going to be completely different from someone with hemoglobin SC or beta thalassemia or someone who has SD. So when dealing with sickle cell disease and the patient itself, we have to be handled on a case-by-case situation. We cannot all be placed in a bubble, and living with sickle cell disease has taught me that, and the transition from pediatric care to adult care has taught me how to advocate for myself better and to also advocate for other sickle cell warriors who may not know how to advocate for themselves. So this disease has taught me so much about myself and also has helped me to educate others on how to treat individuals living with sickle cell disease. Growing up, it was always difficult for me to understand how to educate others because I was the only individual living with sickle cell disease that I knew who had it. None of my church members had it. No one in my community had it. No one in my family has the disease. So I was going through this by myself. And my parents were basically informed, I want to say maybe when I was around 7 to 8 months of my diagnosis. So they were learning as I was learning. So anytime that I had the opportunity to educate someone else about it, I took that as a stepping stone to learn and also to help them learn. And I just didn't understand that at the time that was called advocating. So I've been advocating since elementary school. So for me, it's easy. And I know that that's not necessarily the case for all individuals living with this disease. So it is important that we know exactly what our numbers are, our red blood count, white blood count, where our levels are on a regular basis on a good day, that we build those relationships with the hospitals that we frequent or the clinics that we frequent, and that our relationships with our hematology doctors and our PC doctors are cemented, because if not, we are left dealing with this disease by ourselves. So you're not only dealing with the complications of sickle cell disease, but you also are learning that your organs are fighting it, your bones are fighting it, your skin is fighting it. So there's so many things that we need as a community, as a whole, in order to grow. I was talking through social media the other day, asking other sickle cell warriors how many specialists and doctors they see. And living with this disease, it will let you know that you need a cardiologist, you need an ophthalmologist, you need so many people in your healthcare team to help you learn the best way to take care of yourself. Because this disease, it affects the organs, it affects the spleen, it affects the heart, it affects the lungs. You really have to be careful and mindful of the things that you eat, you consume mentally, spiritually, and physically in order to keep yourself grounded, because this disease, like I said earlier, it is so sporadic that at 6 o'clock, I can be feeling amazing. And by 6:15, I feel like crap. So I'm taking the extra care to drink more water, to eat more fruit, to eat more vegetables, to make sure that I'm communicating with my hematology doctor what's going on with me. It's also important to make sure that your mental health is top notch. Living with this disease will show you how delicate life is. I've lost many friends to sickle cell disease. So I've learned to talk to a therapist about my grief, about my sadness, to identify the triggers of stress, to identify the triggers of sadness, because anything can cause a pain crisis. If I'm not drinking enough water, I can have a pain crisis. If my diet is poor, I can have a pain crisis. If the weather changes, I can have a pain crisis. If I'm traveling or the altitude changes, I can have a pain crisis. So you really have to understand your body and listen to your body and know exactly how to advocate and take care of yourself, because you only get one life. This is your body, so you have to take care of it. And I advocate that so, I stress that so importantly when I'm speaking at St. Jude to the transition groups, that you are the only one in the hospital that is building this connection with this emergency room doctor or nurse or this attending doctor. So your voice matters. What you say matters. There are several individuals with sickle cell on my Facebook Live right now who are having a difficult time because doctors don't believe our pain. They take our pain for granted, or they don't believe that it's real. Because a lot of times when we're dealing with that type of situation, we've been taught to rely on our distractions to help us not to focus on the pain. So if I pick up my cell phone and I'm talking to my sister, or I'm playing a game, or I'm watching Netflix or whatever to distract myself from not thinking of the pain, if a nurse or a doctor comes in and they see me on my phone, they automatically assume that my pain isn't real, or that I'm not in pain because I'm on my phone, when in reality, sickle cell warriors are taught to use distractionary methods so that we can focus on other things, so the pain is not the first thing we think of, because the pain can be so intense, it can be so taxing, it can be so mentally draining that you will slip into depression, that you will have suicidal thoughts. Your mental health is very important when you're dealing with sickle cell disease, and it's just one of the many things that we have to be on top of. I looked up the definition of equity, and the World Health Organization defines equity as the absence of avoidable, unfair, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other means of stratification. Healthy equity, or equity in health, implies that ideally everyone should have a fair opportunity to attain their full health potential, and that no one should be disadvantaged from achieving this potential. Individuals with sickle cell disease do not have that luxury. This definition does not apply to us because there is a lot of medical disparities when it comes to individuals with sickle cell disease, because people are so conditioned, or they've heard over time that sickle cell disease is a Black disease, and that's not the case. It's genetic. Just like the previous speaker said, you can have sickle cell disease and have a Asian background, Hispanic or Latino background. You can have a background from the Middle East, from South America, from anywhere. It's genetically disposed and based on your genetics. My mother has the trait and my father has the trait, and I was the firstborn. And there is a 1 in 25 chance, no, 25 out of 100 chance, sorry, that each birth will produce an individual with sickle cell disease. So that's how I ended up with the disease. My parents didn't know anything about sickle cell disease at all. They were informed when I was born what it was and had to learn as I learned. So it's very important that we take accountability for who we procreate with. Make sure that your mate gets screened for sickle cell trait. Make sure that the person that you want to have children with gets screened for sickle cell disease. That is the way that we prevent those numbers from climbing. That is the way that we continue to educate people about sickle cell disease. That is the way that we increase awareness. It's about education. It's about advocating. It's about letting people know that this disease is real, and that our voice isn't silent, and that we are important. And that's my job, and I take it very seriously.
Thank you, Tabatha.
Thank you for having me.
Absolutely. You gave us a lot of important information.
I
And
did. I'm sorry.
oh, that's okay. No, that's what we wanted to hear for. And I'm certain that those in the audience really enjoyed hearing you because each time that you speak, I hear so much from you as well. So at the end of the show, we're going to take questions.
Okay.
At this time, I'd like to bring up the next guest. Yvonne Carroll is someone who I work with very closely. Yvonne works at St. Jude Children's Research Hospital. She serves as the Director of Patient Services in the Department of Hematology. Yvonne serves as a lawyer. She's a nurse, and she's also a United States veteran. And we'd like to thank her for serving our country. So at this time, Yvonne, we'd like to bring you up to talk about sickle cell disease. Hey, Yvonne.
Hey, how you doing?
We're doing great. Great having you.
Well, thank you. Of course, you would make me follow Tabatha, right?
Yeah, Tabitha's pretty tough to follow. Because I'll tell you, we're going to talk about that later. But, each time Tabitha talk, I learn more and more about sickle cell disease. She's wonderful.
Absolutely. So I'm going to share my screen now. This is actually the perfect time to talk about health disparities and sickle cell disease, because sickle cell disease doesn't exist in a bubble. Can we get the slideshow version of it, of my screens? No? Okay. Well, let me see. Is it possible to get the slideshow version from the beginning? All right.
Yvonne, you can control that portion.
I can't.
Okay. We should be able to, but we're figuring it out. Can you do it manually?
Can you see my screen?
Yes, we can. Now we see it.
Okay. So, so let me see if I can. Oh, wait a minute. I'm gonna go to the beginning. I'm sorry. I'm old and I'm technologically challenged, so forgive me. Okay. So now is a great time to talk about health equity and sickle cell disease, because sickle cell disease doesn't exist in a vacuum. And it would be impossible to ignore what's going on right now in the country with the Black Lives Matter movement and with the pandemic, both of which affect people with sickle cell disease. So, okay. So, Tabatha got the World Health Organization version. I got the simplistic version of what is health equity and the difference between health equity and health disparity. So, what is health equity? Everyone should have the opportunity to be as healthy as possible. That's it. I mean, everyone should be able to live up to their potential as far as their health is concerned. And so what's health disparity? Health disparity is the difference between health outcomes and their causes among groups of people. So just to take an example of what's going on right now with COVID-19, people of African American descent and Indian descent are 5 times more likely to have COVID-19 and to have severe outcomes. And people of Hispanic descent are 4 times more likely than their white counterparts. So that's health disparity. So you can't talk about health equity without talking about health disparity. They just blend together and mesh, and it's impossible to talk about one without the other. In many places, they're considered the same. So the CDC put this together, and they talk about health disparities and sickle cell disease. So what I was talking about, you can't, sickle cell disease doesn't exist in a vacuum, because environmental factors affect it, economic factors affect it. You have anything that goes on in the environment that affects it. So the average life expectancy, 30 years shorter than people without sickle cell disease. That's a huge disparity. The rate of hospitalization, highest rate of returning within 30 days of being discharged compared to other health conditions. The rate of stroke in ages 35 to 64, 3 times higher than African Americans of similar age without sickle cell disease. The majority of sickle cell disease patients are Medicaid beneficiaries. So that impacts the access to health care. More than 70% of doctors don't accept new Medicaid patients. So you have over half of the patients with sickle cell disease don't have access to 70% of the doctors. And as Tabatha talked about, sickle cell disease is not just about seeing your hematologist, because as you age, you're going to need to see other specialists, and you're going to need internal medicine doctor. You're going to need the cardiologist, just as Tabatha mentioned. And also, you are susceptible to the same diseases that other people are susceptible to. So in addition to your sickle cell disease, there are other diseases that just as a function of aging that you're going to be susceptible to, and you're also going to be at increased risk because of your sickle cell disease. Healthcare providers, and I think everyone that, if you talk to anybody with sickle cell disease, they will tell you that they inaccurately perceive people with sickle cell disease as drug seekers and doubt their pain. Just as Tabatha said, a lot of times people with sickle cell disease are not believed. And a part of that is because sickle cell disease is an invisible disease. So I can't look at someone and tell that they have sickle cell disease. But if I go to the emergency room and I break my arm and my bone is sticking out of my arm and I have blood dripping down, that's visible. Nobody is going to make that person wait in the waiting room. But if I come to the emergency room with sickle cell disease and I'm in that same degree of pain, and honestly, the exact same thing is happening, because that person with blood dripping out of their arm for a break is basically losing blood. So they're losing oxygen to their tissue. Person with sickle cell disease, it's a different mechanism. You are, you have your blood is clotting, so you're not getting oxygen to other parts of the body. So the degree of pain is the same, but it's not visible. So a person with sickle cell disease may wait in that waiting room an hour or 2 hours versus being walked straight back. And so the number of physicians trained and willing to treat sickle cell patients, especially adult patients, is limited. So even we already talked about over almost half of the people with sickle cell disease are on Medicaid. So that just blocks out a huge number of physicians that they can see, access to care. But then another is access to care, and you don't have, even of those doctors, you don't have doctors who want to treat sickle cell patients. So even that other 30% may not accept sickle cell patients. So all of these lead to health disparities in people with sickle cell disease. And so I just happened to see this. Doctor says pandemic reveals enduring racial inequity. Medicine alone can't fix. And I don't think that's surprising to anyone. I think everyone understands that. Everyone realizes that this problem is bigger than just medicine. And the one thing I have to say about the Black Lives Matters movement is that it has brought attention to people of color and the inequities in people of color, and governments and organizations, institutions are all trying to make accommodations, and they're all looking to say, what can we do to help fix this? One of the huge things is, even though sickle cell disease does not only affect African Americans, in the United States, that's the majority of the population. But throughout the world, that's the majority of the population of Black people and people of color. have sickle cell disease. So Hispanics, people of Mediterranean descent, mostly people of color. And if you look at the statistics from U.S. medical schools, graduating 350 or more Black physicians, and this is in a 32-year period from 1980 to 2012. This is, if you look, this is only 17 medical schools that graduated more than 350 Black physicians in 32 years. And if you go down to the bottom, some of them graduated less than 500, which averages to less than one per year. So this is the top 17. They're out of 350. So what are the other schools doing? Practically nothing as far as um, graduating physicians of color. So there are a lot of possible solutions, and I won't get into all of those, but there is a systemic problem that needs to be addressed. And it needs to be addressed. It's not just something that can be addressed with the healthcare system. So this problems have to be addressed at both the systemic level and the institutional level. So on the systemic level, you have just society at large, education. How does education impact sickle cell disease? Well, health literacy is huge. If you can't, I had a patient one time that a parent actually was a caregiver of a child, and the child was in clinic but needed to go to the emergency room. And so I said, I will walk you to the emergency room. This child is in, needs to go to the emergency room to get treatment. And the father was a really good father, and he didn't want to go. And he said, I want to go home and get my wife. Well, he lived 2 hours away. And I said, no, that's not really a good idea. I said, we need to take your child now to the emergency room. And he kept saying, no, I want to go home. And so finally we started talking, and I said, well, what's really the issue? I mean, why don't you want to go to the emergency room? And he said, I can't read. And he said, they're going to give me forms and I'm not going to be able to fill them out. And so this was something, education impact. Of course, I took him down and we walked through, but that's huge. I mean, it would have affected that child possibly not getting the urgent medical treatment that the child needed because of education. Income. Well, we all know that income is huge. I mean, having insurance, it goes to housing. Anecdotally, I don't think I've ever read anything about people with sickle cell disease and housing, but just anecdotally, I've been in this for over 20 years. Talking to people with sickle cell disease, I have noticed there is a very high rate of people who live with either rent rooms or live with a roommate, or sometimes best case scenario, they're able to stay at home with their parents. Housing is very difficult for people with sickle cell disease. And that's not something that can be addressed by the medical institution. It causes a health disparity because if you don't have any place to live, or if you're worried about you're going to get evicted, that's going to impact your health because stress impacts health. And it, of course, as Tabatha said earlier, if you're stressed out, you can have a pain crisis. And so even though we don't think of it as a disparity that affects sickle cell disease, it does. Jobs, of course, anybody with a chronic illness, if you have a severe chronic illness, it's going to be difficult to maintain a full-time job. I talked to one gentleman and he just was in tears. He said he had sickle cell disease, and he said, I want to be the breadwinner. I was raised that I should be able to take care of my family. And he said, sometimes I can hardly move, but I make myself get up and go to work. And I know that that's not good for me, but I just have it instilled in me that I need to be the breadwinner of the family. And so, knowing that you're doing what you're doing to your body, but still knowing that you have to keep this job, That impacts your health. Geography, where you live impacts your health. If we'll just go right to the next one. If you live in an area with a high crime rate, it has been shown you are in increased risk of certain type of cancer. And the reason for this is because you're stressed. Well, stress and sickle cell disease go hand in hand. They are, they're intertwined so closely that anything that causes you greater stress is going to cause problems. I had a mother tell me, and all I could do was listen because this is something that is beyond the capability of the medical system. But she said that every year she had faced eviction for her house. She said somehow she pulls through, but every year she has faced eviction because she has a child that has severe sickle cell disease, and she had to be in and out of the hospital with that child, and she would lose a job, and she would have lost income. And so, those things are stressful to the parents. Of course, that stress trickles down to the child and affects disease. We already talked about access to care. If you don't have access to a medical facility that has the same um, specialist as other people, that's a health disparity. So the trend is for many health institutions to move out to the wealthier suburbs. And the reason for this is obvious. They want to make more money. Well, that's not where the majority of people with sickle cell disease live. So just geographically, you can be distant from access to care. So if you are in an area that has a hospital that doesn't have access to specialists or doesn't have access to hematologists, you're at a disadvantage. So you can't live up to your best health outcomes. So racial inequities, I don't even think I need to talk about that. It's going on every day. It's playing out in the news. I think everybody is aware of racial inequities in healthcare, and it in that is implicit bias and the access to culturally competent healthcare providers. And so all of these are systemic problems. So institutional problems are problems at a specific institution. So there are several things that can be done at an institutional level for healthcare. So substance over show. So what that means is an organization can't just say, "Oh, we're going to do better for people with sickle cell disease." You have to have a plan with an outcome that you want to do. If you want to have a greater level of um, a lower level returns for people in 30 days. So you have your baseline, whatever your baseline is now, say, I want to improve that baseline by a certain percentage over a period of time. So those are hardcore things that you can look at, you can measure, you can see if you actually made a difference for people with sickle cell disease. So everyone in the institution has to be involved. It can't just be the physicians or the nurses, because I tell you what, if you go in and the registration person has you sitting out in the waiting room for 2 hours, it doesn't matter if the doctors in the back are the best doctors and nurses in the world. If you don't have access to them, it's not doing you any good. So everybody in the institution has to be involved and has to be committed to healthcare equality. So you can't start with the easiest things. So I might say the easiest thing is for me to get someone registered in 30 minutes. But they might get registered in 30 minutes and still sit back in the waiting room for another hour and a half or 2 hours. Well, what's the most important thing? You want pain medicine within 30 minutes. So start with the thing that's going to have the most impact, not just the thing that's the easiest to do, the thing that you can say, hey, look, we did something. Start with something that has impact. And then look at the barriers from a different perspective. Don't just have the same eyes that you've always had. For instance, if you have a survey most hospitals send out surveys for people to rate their visit. So if I say, if you just break out the survey and the institution as a whole might be 90%, but if you break that out and look at disease and you say people with sickle cell disease have 30% lower satisfaction, then that's a huge problem. So look at things from a different perspective. And then the journey must be undertaken as a group. So everybody has to be involved. You have to make a commitment to address implicit bias. As stated before, we know that most of the healthcare staff are going to be are not going to be as culturally diverse as your sickle cell population. So that has to be something that the hospital is willing to address, and it has to be from the top down. The head of the institution has to show a commitment, and they have to make some hard choices because this is not easy to do and it won't happen on its own.
Well, thank you, Yvonne.
Thank you.
Thank you very much. That was a very, very good presentation. So, ladies, at this time, we're going to jump right into the questions. We have a lot of good questions. So let's start with the first one. Tabatha, I'm going to direct this to you. The question is, when a patient is experiencing a pain crisis, is it common for them to go to the ER, or is the medication that is prescribed to them is sufficient?
It really depends on the individual warrior and the level of pain. Personally, I would rather deal with it at home and go through the process of making sure that the pain can be handled and that it continuously is steadily decreasing before I go to the emergency room. Before I go to the emergency room, unless there's a head issue or head pain or chest pain, or I have a temp of about 101, then I go to the emergency room. Any other time, I try to manage at home through my resources and try to manage the pain myself.
Okay, thank you. The next question is, for someone who does not have sickle cell, what's one of the things they can do to help spread the awareness?
The easiest way would be to find your local community-based organization and to see if you can work with them. Talk to another warrior who has the illness and ask them what way you can support them individually, or you can call up your local hospital and see what ways that you can help. Also, you can donate blood. It just depends on what area you would like to give to.
Okay. Dr. Aguinaga, this question is for you. Can you tell us once again, as related to how are you tested for sickle cell disease or sickle cell trait?
Yes. Tennessee since 1968 has been doing newborn screening for sickle cell and sickle cell disease and sickle cell trait. The methods that are used right now are chromatographic by high performance liquid chromatography and also electrophoretic. Now, in the case of rare combinations of hemoglobin variants, then you do need to do DNA analysis. But if some of the members of the audience have been born in Tennessee after 1989, definitely they have been tested at birth, and most likely I have seen your blood in the lab.
Okay, thank you. The next question, I'll direct this to anyone. I think we all know the answer. However, is there a cure for sickle cell disease?
No. There is no cure for sickle cell disease. There are several treatments and research that is going on as we speak, and several trials to see if there are ways to help individuals living with sickle cell disease. But as of 2020, no, there is no cure.
Now let's talk about the bone marrow transplant and potentially some of the difficulties with it. Uh,
So, so like Tabatha said, there is the cure is not easily accessible. Bone marrow transplant has been around since 1983, and it's just not easily accessible. You have to have the best outcomes are with a full brother and sister, and only about 15% of them will be a HLA match. So so it's not readily accessible, and it hasn't not been extensively used in sickle cell disease. Now, what we are researching, many companies are doing this, and I hold great hope for this. Gene therapy. I think gene therapy is going to be, yeah, right, worldwide. I think it's going to be a game changer. Uh, but that will be a cure for sickle cell disease.
okay, great. Thank you very much, Yvonne. The next question is it important to inform your friends and associates that you have sickle cell disease in case if you go into a sickle cell crisis?
Absolutely. I blacked out in college and was not aware of anything that was going on. But because I had built those special relationships with my schoolmates, with the women who were in the same dorm as I was in, they knew who to call. They knew my doctor's information. They had my brother's cell phone number. They knew how to get in touch with my mother. They knew my blood count. Like those women saved my life. So of course it's important for the people around you to know what's going on, because you can be out having fun one minute and the next they don't know what to do. So they can be a danger to you if you don't vocalize what's going on with you. And you have to remember that it's not people being in your business, it's you looking out for you. So absolutely tell them.
Dr. Aguinaga, I think Tabatha mentioned this, but talk about dating. What are some of the concerns of what should happen if someone is dating to discuss sickle cell disease?
Yes, Mr. French, I was very happy to hear Tabatha said, testing and education both go hand in hand. If you are contemplating having children, be informed, have your partner tested. And then, she was saying you have 1 in 4 chances, if both have sickle cell trait, of having a baby with sickle cell disease. So St. Jude's, Meharry, and other CBOs in the state perform community testing for free. Meharry, between February and November each year, almost every other weekend, we go in the community and we offer free testing for sickle cell trait and free education. Education and testing, they go hand in hand, and that is the number one thing that we need to do if we want to decrease the incidence of sickle cell.
Agreed.
Okay, Dr. Aguinaga, I think you may have answered this, but I want to ask the question as well for the audience. Does Meharry treat and do research for children and adults?
Meharry Medical College sees the sickle cell disease children. The first visit is at Meharry Pediatrics. We bring them to the clinic. And we are going to reopen the adult clinic in the fall. Right now, we are in between hematologists, but we're going to reopen the adult clinic. At this point, the research that we have research in sickle cell trait. As you know, we have between 2 and 3 million people affected with the trait in the country. And we have sickle cell disease data research as well. In the past, we developed an animal model, a transgenic sickle cell model for sickle cell disease. And we tested different drugs, among them hydroxyurea, and its effect on reproduction. And at this point, we are working with data. Now, other institutions, Vanderbilt, Centennial, they are doing active research, clinical research with patients. If the person is interested in being in a clinical trial, also St. Jude's, please contact them. or contact us, and we will bring the bridge. We will put you in contact with them as well.
Okay. Next question is regarding St. Jude. Yvonne, you leave St. Jude at what age if you are diagnosed with sickle cell disease?
So we take care of children from birth to 18 years old, and we take care of about 900 children with sickle cell disease. Tabatha was one of our stars. uh, but we have a transition program with the adult center at Methodist, and we work with the Med One and Regional One. I'm sorry. So we have a transition clinic from 18 to 25, and it's for continuity of care because people like Tabatha came back and told us, hey, look, transition is tough, and we need some help. And so we decided, okay, let's see what we can do about this. And so they're seen by one of our pediatric docs and an adult doc in the transition clinic to help continuity of care.
Thank you. This will be our last question. This is for Dr. Aguinaga. COVID-19 has brought an additional worry for many people, certainly those with sickle cell disease. So please tell us, as it relates to, what would you encourage a sickle cell patient to do during this time?
Thank you. Last Thursday, CDC, as you may be aware, updated the list of diseases that have to be considered high risk for COVID-19, and they put sickle cell disease. So I would say the number one thing is to prevent the infection. And by that, to practice washing your hands, social distancing. If you're going out, wearing a mask, and keep your distance, at least 6 feet away from people when talking. Because right now it's not clear. I mean, the virus is not airborne, but it can be transmitted through air droplets. Okay, so wearing a mask will protect you from that. It is not clear if it can be ingested, because still we don't have enough studies. But prevention, to me, is the number one thing that we need to do. And I was glad when Tabatha said, if you are having a lot of pain, should you go to the ER? First, call your doctor. Try to minimize potential sources of contagion. That's the number one thing we need to do. Okay, so sickle cell is considered high-risk disease for COVID-19 as of last week.
Thank you. Well, I'd like to thank each of you for joining us on tonight. More importantly, I'd like to thank our panelists. I think it's been a lot of helpful information for the audience. And I would encourage those individuals who have any questions, please contact our foundation, or you can reach us on the web. So we look forward to seeing you next month. Thank you very much for joining us tonight on Sickle Cell Today.
Hi, Tabatha and Pilar.
Bye.
Bye.
Take care.